Hi everyone. Today I'm going to be presenting an acute care case study for a patient that I treated at my first clinical affiliation at Cooley Dickinson Hospital. Just to give you all an overview of this patient, he is a 76-year-old male that I treated immediately following a left total knee replacement. So the reason why I chose this particular patient is that I was actually able to follow his progression from pre-surgery up until the day of discharge from the hospital. So I was able to speak to him about an hour before his surgery, just got some background information, and then I was able to go into the operating room and observe the surgery, which was very interesting, although I am very shocked that I made it through the whole surgery still upright. And then immediately following the surgery, I was able to treat him day one up until he was discharged from the hospital, like I said. So seeing the entire process from start to finish really pieced together the entire acute care rehab process for me. Being able to observe the surgery, interact with the surgeon, really empowered me to more fully understand the patient's pain and allowed me to answer the patient's questions more appropriately, and also to gain a better understanding of exactly what structures were involved during his surgery. So medically speaking, this patient was diagnosed with chronic left knee pain along with osteoarthritis in the left knee with something called CPPD, which stands for calcium pyrophosphate crystal deposition. So in this case, calcium crystals rub against soft tissue formed in the cartilage at the end of the bones. It's similar to the symptoms of gout, which is why it's called pseudo-gout, but it's actually caused by calcium crystals rather than the waste product urate. This patient had a rather short list of past medical history, including DVT, hypertension, and GERD, which is essentially acid reflux. His past procedures included a right total knee replacement, which was done in September of 2019, a bilateral ankle fusion, and a rotator cuff repair. Some of the medications this patient was on prior to the surgery were Eliquis, Colace, Nexium, and Microzide. The patient was advised by the surgeon to stop the Eliquis 48 hours prior to the surgery due to this medication being a blood thinner. Post-surgery, he was on oxycodone for pain management as well as Zofran for nausea control. So what happened that led to this point? Similar to any other patient needing a total joint replacement, this patient had severe debilitating osteoarthritis in his left knee, which caused him chronic pain that could no longer be treated by conservative measures. As I mentioned previously, this patient was also diagnosed with CPPD. This condition can lead to severe painful attacks and chronic pain and inflammation, which accelerated his osteoarthritis. This patient was not using any assistive devices at baseline, but he did state that he had owned a cane and walker to use once he was discharged home. This patient had a rather simple psychosocial background. He's retired, lives at home with his spouse, and is independent with all ADLs and IADLs, which include more complex skills such as managing finances, handling transportation, shopping, managing medications, and basic home maintenance. Home support availability is a crucial aspect when a PT is determining their recommendation of discharge for a patient. In this case, at discharge, the spouse was very supportive and stated that she would be giving the patient 24/7 care at home. Since I thoroughly communicated with the PT about being involved in this patient's entire acute rehab process, I was able to observe the evaluation. This patient was evaluated the day of surgery in the afternoon. During the evaluation, the PT first obtained environmental context information and pain assessment. In this case, the patient stated he lived in a 2-level home with 1 flight of stairs to his bedroom and bathroom. He also stated there were 2 stairs to enter his home with no railings, which is important to note to be able to provide the patient with proper mechanics and education regarding navigating stairs. This patient's initial pain assessment was 1 out of 10 in his left knee, along with range of motion measurements of -2 degrees of knee extension and 110 degrees of knee flexion. For anyone not familiar with the acute rehab process for total knee patients, These measurements are not typical. A majority of patients that I treated during these 8 weeks had a severe amount of surgical pain in their knee and substantial limitations in range of motion. A patient typically presented with, on average, about negative 10 degrees of extension and 80 degrees of flexion. This is why PTs take a very aggressive approach on regaining range of motion following this surgery. There were no significant strength limitations for this patient in his left lower extremity, with 4 out of 5 knee flexion and 4 out of 5 knee extension. Despite 4 out of 5 strength in both knee flexion and extension, lower extremity strengthening and motor control was a vital aspect addressed as part of this rehab process. Following a total knee replacement, goals are oriented towards improving functional mobility. These include bed mobility, functional transfers, gait and ambulation, and stair management. I will give you all a minute to read through the goals for this patient. To align with this patient's goals, the interventions provided focused on therapeutic exercise and activities and gait and stair training. For therapeutic activities, I addressed bed mobility and functional transfers. For bed mobility, it is making sure the patient can safely and independently get in and out of bed. In some cases, patients may need to use upper extremity support or a towel or sheet to help assist with their operated leg due to weakness and lack of range of motion. In addressing functional transfers, it's ensuring the patient can perform stand to sits and sit to stands from multiple leveled surfaces. This is important and essential to practice transfers from bed height as well as toilet seat height. In some scenarios, a patient may need adaptive equipment for home to be able to safely perform these transfers. Transferring in and out of a car is not necessarily a task that we can practice in the hospital setting. However, if a patient or family member has questions, we provide them with education on a safe car transfer. Typically, it is best for the seat to be pushed all the way back to give the patient room to swing their operated leg into the car. Therapeutic exercise is an important aspect in the rehab process following a total knee replacement. At this stage, simple bed-level exercises are introduced to maintain and build lower extremity strength to make it easier for the patient to independently perform functional transfers. Some exercises commonly prescribed are your simple isometrics, such as a quad set and glute set, ankle pumps, supine hip abduction, short arc quads, and long arc quads. To encourage range of motion and movement of the knee joint, exercises such as heel slides and seated knee flexion are performed. Gait and stair training are a major part of the rehab process. To ensure safe ambulation and stair negotiation, these tasks need to be addressed. Following a total knee replacement, patients use a wheeled walker for ambulation in the hospital, regardless of their functional ability. Regarding stairs, a cane or crutch may be used, depending on the patient's preference and safety concerns. This patient was slightly impulsive at times. He needed cues to slow down and to emphasize safety with all transfers. However, just as with his minimal pain and excellent range of motion, he was modified independent throughout his entire hospital stay through all visits, with all functional mobility, and demonstrated good strength by performing all exercises actively. As previously stated, this patient was not typical. He had met all goals after one session. He demonstrated independence in bed mobility and transfers, and modified independence with ambulation and stairs, all while complaining of minimal pain in his operated knee. This patient was in the hospital for a total of 2 days, which is a typical duration of stay for a total knee replacement, and he was discharged home with physical therapy. Prior to discharge from the hospital, I did provide the patient with education on his impulsivity and to make sure that he didn't overdo his exercises because it would irritate the knee and cause inflammation and increase pain. During the last visit prior to discharge, on the day of discharge, He reported pain in his left knee at 1 out of 10. Range of motion measurements were taken. Knee extension was -2, and knee flexion at 100 degrees. As part of the EMR system used at the hospital, I was able to access records of his home PT visits. He was seen 2 days after discharge with home PT. His range of motion at this time was -5 degrees of extension and 88 degrees of flexion. As you can see, this is a big fluctuation from when he was discharged from the hospital, with his extension being -2 degrees and flexion at 100. Despite his excellent and consistent range of motion in the hospital, this is the normal response. Range of motion tends to fluctuate greatly depending on any activity done that day. On the second home PT visit, range of motion was measured at -5 degrees of extension and 90 degrees of flexion. There was increased edema in his knee due to reported excessive activity. All in all, I hope you all have a better understanding of the acute care physical therapy process following a total knee replacement. For myself, having this exposure to this setting and just getting to witness and treat a patient and see them progress through the whole acute rehab process was such an integral part of my education. The one big takeaway that I want everyone to remember is that no matter what setting you always want to treat the patient, not the diagnosis, because every patient is going to present differently. So really it's all about finding what techniques or exercises are really going to work best for that patient, not the diagnosis. At this time, you can write down any questions that you may have for me about this presentation, and I will be glad to answer them when we all get together and go over our presentations. In the meantime, I hope everyone is staying safe, and I look forward to seeing you all soon.